You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by Continuing Education Company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
All right. So David, who's an executive in my healthcare system, 45-year-old gentleman, came to see me. Ongoing care, he has hypertension and depression, was concerned about weight gain for many years. He now has a BMI of 35. All right, so we get a better history. Doesn't feel like he overeats. Is that what everybody gets, right? No, I don't. I think it's part of the disease of obesity is the neurocircuitry is off there. He doesn't have true bad habits. He's tried every diet out there. He loses weight, but then he regains it. He's worried about his weight, especially now because he was recently diagnosed with sleep apnea and prediabetes. But he's busy. He's got a stressful job. He's got family obligations. It just doesn't feel like he has much time to do anything about it. Here's his current treatment regimen, his current family medical history, and then his BMI is over 35, blood pressure not well controlled. He has central obesity, otherwise normal exam. All right, got some labs. Triglycerides are mildly elevated, LDL 125, A1C 5.9, and I believe he had another reading somewhere that confirmed the prediabetes diagnosis. All right, so he has class 2 obesity. I like the ABCD thing that Dr. Garvey has, with numerous obesity-related complications. OSA, hypertension, hyperlipidemia, prediabetes, and who knows what else he has that we haven't looked for. He doesn't have a clear secondary cause. Maybe the antidepressant might have some effect. He doesn't clearly have Cushing's, although maybe we should be looking for subclinical Cushing's. He's gaining weight despite not overeating, which is, I think, an issue for a lot of people. If you look at the stages of change, which I think are really important when you're managing obesity or any chronic disease, is where are they in the stages of change? And he's in that pre-contemplative. He understands it's a problem, but he's not really ready to do something about it. He's got a lot of barriers, specifically little time, a lot of stress. So those are things that we need to worry about. All right. So what would you recommend next regarding management of his obesity? So I'll let you read those and answer. All right. So 86% of you said one of the above and add an obesity medicate. I would argue that all of these are right. They're very good. Yeah, commercial weight loss programs work. I think we underutilize them. Initiate lifestyle plan. That's fine if you have time for it. I'm not sure that most of us have time for it. Adding a medicine, we want to do that on top of lifestyle. Certainly, he's a candidate for it. He's a candidate for bariatric surgery. There's no reason not to consider it even up front and have a discussion. Having said that, I say E. He's not ready for any of these things. He's pre-contemplative. We need to get him ready to lose weight so that we can have success. We can go the easy way, just write a prescription and say, see you later, see you in 3 months. But I think our goal really should be to help this guy understand how important his weight is in relationship to his health problems so he can then be in the action phase and really do something about it. I bet you if all you did was initiate lifestyle counseling, that was not going to work. And then we're going to be frustrated. Oh, he didn't listen, he didn't do anything. It's because he wasn't ready. We need to get him and prepare him to be ready. All right. So remember, our primary goal with this guy would be to educate him about the impact of his weight on his health and prepare him for weight loss. And it might be tomorrow. Maybe he gets back to you on your inbox and says, hey, I'm ready. I'm ready to do something. That's great. But we need to prepare him for future weight when he's ready. We want to maybe prevent further weight gain. It might be reasonable to check a TSH. Maybe we do a low-dose suppression test. I think it's reasonable to consider other markers of risk. Is FIB4, BNP, urine albumin. These are all things that might further enhance our decisions to be more aggressive. We might change his antidepressant to something more weight-friendly. Would something like bupropion be better, be effective for him? We want to reduce and eliminate those barriers. I think that's the most important to ensure that we have success down the road. Getting more information, having him track his diet, having him track his activities, all those are going to be important and help him understand the importance of lifestyle. Okay, he comes back 6 months later. He's ready. He's motivated to lose weight. He needs to be concerned about his weight and overall health and getting diabetes. He's heard that there may be new medical options available and is interested at this point for hearing about it. He wasn't ready 6 months ago to hear about these treatments. All right, what are our options? Actually, I think that's on the next slide. What would you recommend for this guy? All right. So 95% of you say all of the above. Well, let's go through that real quick. Set a weight loss goal of 5-10%. That is a reasonable weight loss. That will help reduce his chances of getting diabetes from prediabetes. It'll improve his lipids, his blood pressure. It may not be enough to treat his sleep apnea. So I would say that more weight loss would be better, but I think this is not a bad place to start. And it's reasonable to set reasonable goals. It kind of depends also on what your plan's going to be. If you were just doing lifestyle intervention, you're not going to get much more than 10%. So you don't want to set a 15% weight loss and just set yourself up for failure. Now, if you start him on medical therapy, that might be a different story. I think when you're talking about diet, if there were diets that worked in the past, it's something to consider. If he's never done a commercial program, maybe that would be good for him. The structure, and the education. Meal replacements, we don't talk about that. Those are effective treatments for weight loss. Yeah, they're temporary, but they can help people lose weight in the short term, and then we work on other strategies for long term. Physical activity, the more he does, the better. That may not help him lose weight, but independent of his weight, it's going to help his health and it will reduce his cardiovascular risk significantly. Should we consider starting an obesity medication? The answer is yes, because he's now motivated. Let's take advantage of that. So I agree. All of the above I would go with. Let's see what I said. That is what I said. Yay. Okay. Any disagreement with the panel?
No,
I think all of those things are germane that you said.
Okay. All right. Let's say he is interested in medical therapy, which he did. He came in and said he is. Which of the following obesity medications would you consider? I was going to say, if you didn't get this right, I had failed today. Yes, thank you. Do not recommend medical. No, we should be recommending it. I know you may not feel comfortable with it yet, but you should start getting comfortable. Semaglutide, tirzepatide would be excellent, and there's reasons to do either. Both would give him, I think, a lot of success. I might lean on tirzepatide because of the sleep apnea issue and that indication. I would consider phentermine-based therapy. If he can't get on tirzepatide or semaglutide, I think a common either phentermine alone or phentermines with topiramate, that would give him 10% weight loss. That would be beneficial to his health. And the studies with topiramate and phentermine together, there's good studies that show reductions in the conversion of prediabetes to diabetes. D, I'm not even going to go there. If you had answered that one, I would have been really upset. And E, obviously not. So yes, so B was the right answer. Should. All right, so again, our guide selecting treatments, pharmacotherapy, we consider, this is FDA type stuff, BMI of 30 or higher because they have, quote, the diagnosis of obesity based on a BMI, which we all know is not the only way to diagnose obesity. BMI of 27 or higher with comorbidities or complications. Obviously, this guy meets the criteria. And again, I think these are moving targets. This is a summary table that I had shared with you in my previous talk. And again, this is just more for your reference that goes into the different medicines. Remember, though, that there are contraindications when you're trying to decide what to do. Which medicine should I try? Which one should I not? Remember, pregnancy is contraindicated in all of these drugs because weight loss is contraindicated during pregnancy. But do remember pancreatitis, personal family history of medullary. It's not regular. They've had papillary thyroid cancer. It's perfectly fine to put somebody on a GLP-1. But pancreatitis one, I think, is important. And there's still a suicidality issue, even though the data are not necessarily clear on that. and then looking at the other medicines. So at the end of the day, you have to make a decision with your patient. We've decided on medical therapy. I think, how do we decide which one? At the end of the day, cost is a huge factor, because if they can't afford it, it doesn't do you any good to write the prescription, right? Patient preferences is important. My friend lost 30 pounds on Ozempic. I want Ozempic, right? Okay, that's fine. Efficacy, I think, is important as we're balancing this versus contraindications. That helps us narrow it down. The pathophysiology might be important, underlying behaviors. We did a small study years ago where we took a group of people and put them all on phentermine. And before we started them on phentermine, we asked them about hunger. We did hunger scores. Our anecdotal data from our clinics was that people who eat out of hunger lost more weight on a drug like phentermine, which blocks hunger. And we actually showed that in very small, 30 individuals, but it showed that if you didn't eat out of hunger, meaning your hunger scores were low to begin with, you didn't lose much weight with phentermine. So again, underlying behaviors might impact. If you eat out of cravings with a drug like bupropion, naltrexone be a good option for you, just to think about other ways to narrow it down. All right, after reviewing the options and in light of his moderate OSA, we decided to start him on tirzepatide, which was covered under his insurance plan. Woohoo! That's a rarity, and we celebrate. We did this in addition to providing lifestyle counseling. 3 months later, he was able to titrate the tirzepatide to 7.5 milligrams weekly, and he's tolerating it just fine. And he has lost now 20 pounds. His blood pressure, triglycerides, and A1C have all improved, and he thinks his OSA is better. Just personally feels like it's better. So but we haven't measured that directly. He'd like to lose more weight, but also heard that he should be worried about losing too much weight and losing muscle. All right. So what would you do next? All right, so you guys are smart. You go to the one that's the multiple answers, right? Yeah, you could continue current management, so he's doing well, but he wants to lose weight, and I think more weight loss would be probably beneficial, especially for the sleep apnea issue. So I would increase his tirzepatide to 10 milligrams and even consider titrating it up to 15. Again, you don't have to titrate it all the way up. I think lower doses are okay if patients are doing well. I would not stop the tirzepatide because he's done well with it, because his weight's just going to come right back. I would make sure he's doing resistance training and getting adequate protein, so I think B and D would be my favorite answer.
As it was an option for keeping him right where he is, plus resistance training, I might do that also. So,
sure.
And I don't know if he's reached equilibrium weight loss on the 7.5, where you are with that, but if it's like, less than if it's only a month and you're considering what to do next, I might just keep him on it, given what his predilection.
Absolutely. Is he still losing weight? Is he plateaued? Yeah, et cetera. All those might help you decide. Absolutely. So a couple of things, again, summary on how I use these medicines. First is remember to set clear goals with your patients, set expectations that are realistic. Patient comes in and they think they're going to lose, 100 pounds just because the last person did it. That's not necessarily reasonable. We need to stress the importance of healthy, high-quality diet with adequate protein, hydration, and I think the exercise piece is critical here. I use these drugs with the intention of using them long-term, but with any treatment, I always reassess the benefits and risks on a regular basis, first every 3 months and eventually every 6 months or so. And then there may be a point where we we don't know what to do, right? And I think we talked more about this. We consider and reinforce the benefits beyond weight loss. I think that's really important. It's not just the weight, it's his overall health that's getting better. We always want to look and discuss potential risks and adverse effects. Consider the contraindications to treatments or other comorbid conditions when we're going to decide which treatment. Discuss access-related issues and what to do if not covered or not available. Hopefully we're beyond that not available part, at least per the FDA we are. But the access issues are real, and we've all heard it, and it's a work in progress. And I usually have a plan B, and that plan B may be to go to a drug like topiramate and phentermine, whether it's the branded or the generic forms, as an option. I don't see any contraindications in him to using a combination like that. So really do consider older treatments. And actually, there's a study that shows there's an increased rate of prescriptions for the older drugs now, because there's more patients coming in asking for treatment, and they're not eligible to get on a tirzepatide or semaglutide. And so we're seeing a bump in actually the rates for prescriptions for the older drugs. So I think that's good.
Mark, that first point there, setting your goals and expectations, something my primary care colleagues have taught me is this concept of harmonization of treatment goals at the outset. You start with where the patient is. What do they want out of this therapy? What are their goals? What do they want to see happen?
Right.
And it might very well be different from what your goals might be, of course. And they might want, I do want to be able to walk better, ambulate better. I want to feel better about myself. I want my children or grandchildren to respect me more. I want to look better. And then your goals might be the impact of excess adiposity on health, the blood pressure and the prediabetes and all the things we've talked about. So you make your patient aware of the impact of adiposity on health, and you can say, well, this is what I'd like to see in terms of improving your health, and and then you just come to an agreement on where you want to go overall with therapy. Set that up as a blueprint for more into the future. Pick your therapy commensurate with what those goals might be, not only your goals, but how they might be modified by what the patient wants. And that harmonization of treatment goals right at the beginning, I think, is really important, because you fall back on that as therapy progresses, whether it's, really everything you expected or maybe not so everything you expected, and why you might need to change treatment, this sort of thing.
Yeah, no, that's so important. And I think I want to emphasize also the intention of using long-term. That's a very important discussion of having with our patients, because we know the rates, as we showed earlier, it's abysmal for patients staying on treatments. Now, there's a lot of reasons why they may not be, but one of them is they said, I lost the weight, I don't need this anymore. And we really need to educate that this is a long-term, chronic, serious disease that needs long-term treatment. It doesn't mean that he needs to stay on tirzepatide for the rest of his life. I foresee that we'll be using these super drugs like tirzepatide and the new ones coming out as a temporary treatment to get the weight down over a year or two, and then we transition to other treatments that might be cheaper, easier to take as a maintenance therapy. And I think that's going to be something for the future. We just don't have data right now in terms of what to do for the long term. So, but it's important to have those discussions up front.
Thanks for watching. If you found this discussion valuable, be sure to subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.